Hi, in this presentation, we will talk about the treatment modalities in obsessive compulsive disorder. In this presentation, we'll be dealing with one of the treatment modalities, which is psychopharmacotherapy. We will be talking about the drugs used in or the medications that are used in the treatment of OCD and their effectiveness. The pharmacological treatment of OCD. As in my previous presentation, I had talked about the use of serotonin reuptake inhibitors in the treatment of OCD. I have explained in detail how these are effective, so please go back and watch the first video in this playlist, that is OCD and its causes. So since the early 1980s, several potent SRIs have been studied extensively in OCD. So aggregate statistics for all SRIs, that is serotonin reuptake inhibitors, suggest that 70% of treatment-naive patients will improve at least moderately. So people who are treated with SRIs have very good prognosis, and at least 70% of them improve. So there are different types of drugs which are used in the treatment of OCD. So there can be serotonergic drugs or adrenergic antidepressants which are used. So in this slide, we will talk about the efficacy of serotonergic versus adrenergic antidepressants. The serotonergic antidepressants are mainly the SSRI, that is the serotonin reuptake inhibitors, and the SNRI, that is serotonin non-adrenaline reuptake inhibitors. The adrenergic antidepressants are the TCA. So the serotonic are the SSRI and the SNRI, while the adrenergic are the TCA. So here we will talk about the efficacy of both these medication. So while the anecdotal reports have suggested that clinical benefits can be obtained with a range of antidepressant medication, consistent effectiveness has only been seen or been demonstrated by the SRI. Several studies have directly compared Clomiprimen with other antidepressants, and a consistent pattern emerges. Antidepressant drugs that are less potent SRIs than Clomiprimen are generally ineffective in OCD. And we all know Clomiprimen is a TCA. So in the late 1960s, Clomiprimen was the first reported effective medication for OCD. Since then, numerous placebo-controlled studies have clearly shown Clomiprimen's effectiveness, and this has been confirmed in United States multi-center controlled trial with a sample size of 520. In this study, after 10 weeks of treatment, 58% of the patients treated with Clomiprimen rated themselves much or very much improved versus 3% of the placebo-treated patients. Besides the SRI, Clomiprimen, the newer non-tricyclic SSRIs such as fluoxetine, fluoxamine, paroxetine, sertraline, and citalopram are gaining acceptance as effective alternatives for the treatment of the OCD in controlled studies. Now let's talk about the onset of treatment response, or how soon the treatment takes effect. So it has been suggested that a relatively long period, up to 8 or even 12 weeks, is needed before one can consider Clomiprimen or any other anti-obsessive medication to be ineffective. So we have to give the medication at least 8 or even 12 weeks. Several months treatment is often needed to achieve a maximum response. Long-term treatment. So the treatment for OCD is mostly long-term. Most patients relapse after prematurely discontinuing the treatment, but as stated above, it may take many months for a maximum response to be seen. So initially, just for the response to start showing, it would usually take 8 to 12 weeks, but again, it may take many months for the medication to show maximum response. Pero et al. Reported that 16 out of 18 patients with OCD relapsed within 7 weeks after stopping Clomiprimen. although some had been treated for more than a year, for the mean of which in the study was 10.7 months. All patients regained the therapeutic effects when clomiprene was reintroduced. Leonard et al. Examined the effect of clomiprene substitution during a long-term clomiprene treatment in 26 children and adolescents with OCD, and the mean duration of treatment was 17 months. In the study, half the patients were blindly assigned to 2 months of desipramine treatment, and then clomiprene was reintroduced. Almost 90% relapsed during the 2 months substitution period, compared with only 18% of those kept on clomiprene throughout the study. So this proved that clomiprene was more effective in treating OCD. So therefore, it seems advisable that patients with OCD should be maintained on an anti-obsessive medication for more than a year before a gradual attempt is made to discontinue the treatment. And the maintenance dose needed in OCD is also unclear. So here we can see one of the most effective medication for OCD is clomiprene, and long-term treatment is needed before discontinuing medication. Otherwise, it will lead to relapse. Now let's talk about the drug dosage in OCD. So higher doses of SSRIs have been used in the treatment of OCD than in the treatment of depression, but empirical data supporting this practice are scant. So physicians usually use higher doses of SSRI if we compare to the doses used in depression. However, two fixed dose studies using fluoxetine and one pan-European study with paroxetine, these are both SSRIs, have found some advantage with using higher doses, while one fixed dose study with sertraline has not. So therefore, it seems reasonable to use higher doses in non-responders or when only partial relief is attained. So we can try this technique in patients who have not been responding with the regular dose. So we can start them on a higher dose of SSRI and we can expect some positive outcome. Now let's talk about some of the comparative studies that have been done on clomiprene versus the SSRIs. The introduction of SSRIs has raised the question regarding the comparative efficacy of clomiprene versus that of SSRI. So SSRIs are an important alternative to clomiprene since their range of side effects is clearly different. So we all know that TCAs have a lot of side effects as compared to SSRIs. So while using SSRI, the benefit is the absence of anticholinergic side effects, sedation, safety with overdose. So SSRIs are much safer than clomiprene. So although SSRI may provoke nausea, headache, and sleep disturbances, these side effects are usually less troublesome to most patients than the side effects clomiprene has. Now that we know that there are two main medications that we use in OCD, that is clomiprene, but which has more side effects since it's a TCA, then the other one is SSRI, which has lesser side effects but sometimes may require higher dose. Now let's talk about other pharmacological approaches and neurosurgery. So considered as one of the anxiety disorders according to DSM-4, but not according to the ICD-10, it is not surprising that anxiolytics have been suggested for the treatment of patients with OCD. Thus, alprazolam and clonazepam have been reported as efficient in several uncontrolled studies and case series, and even in a small double-blind randomized multiple crossover study. However, since OCD is a chronic disorder, the long-term use of anxiolytics raises questions of dependency. So we all know that most of the benzodiazepines are drugs which can cause dependence in patients. So that is still the matter of debate whether to use this for long-term, because like in the previous slide we talked, it sometimes may take more than an year to get OCD symptoms under control once the medication regime has started. So despite reports in the open studies regarding the efficacy of trazodone, buspirone, and lithium, results from double-blind studies proved negative. So adding drugs that affect dopamine function, especially at atypical antipsychotic like risperidone, to SRI therapy in patients with treatment-resistant OCD may result in improvement in patients with a personal or family history of tics. So the drug of choice would be clomiprimen, and then the other drugs of choice would be SSRIs. But patients who have treatment-resistant OCD or who have the family history of tics or personal history of tics, if they are treated with an atypical antipsychotic like risperidone, the effect is much more better. So neurosurgery has also been reported to be effective in some patients with OCD, which involves procedure that disconnect the outflow pathways originating from the orbitofrontal cortex. So we had in the previous presentation, we had talked about how the causes of OCD, and there we had discussed the role of orbitofrontal cortex. So you can go back and watch that video to understand this in detail. So neurosurgery has been reported when if there is a procedure that disconnects the outflow pathways originating from the orbitofrontal cortex. So cingulotomy is one of the neurosurgery of choice, which can help patients with neurosurgery, and it can help some intractable patients. But the immediate results may be striking, but the long-term prognosis is more reserved. So what happens in cingulotomy is that the surgeon can use a gamma knife that is like a targeted radiation device, and it is guided to the cingulate gyrus by means of a magnetic resonance imaging, and then the surgeon will make a ½ inch cut or burn to sever the circuit. So the recovery is very fast. It takes around 4 days, but the long-term prognosis of this surgery is more reserved. So earlier, lobotomy used to be done in patients, but lately this particular kind of surgery, that is cingulotomy, has been used in OCD patients who have not been showing a lot of improvement with medications. So now let's summarize the drug treatment for OCD. So the first line of treatment consists of either an SSRI or clomiprimen. Any one of the 5 SSRIs in current use constitutes an effective and safe choice, but choosing which SSRI depends on the drug's pharmacokinetic profile as well as the physician's familiarity with the drug. So the SSRI, like you all might know, they are commonly sertraline, which is also called Zoloft. Then there is fluoxetine, which is known by the brand name Prozac. Then there is paroxetine, which is known by the brand name Paxil. And there is fluoxamine, which is known by the brand name Luvox. And then there are certain other off-label SSRIs which are used to treat OCD, which are citalopram, which is known by the brand name Celexa. And then there is escitalopram, which is known as Lexapro. Then there are certain SNRIs which are also used, and they have been shown to be effective, but they are not FDA approved. And these are venlafaxine, which is also called Effexor, and duloxetine, which is called Cymbalta. So these are the commonly used medication. So the dose should be higher than that used for treating depression, as we talked earlier, and this can be, for example, 40 to 60 milligrams of fluoxetine, and the trial should at least last 12 weeks. So like we talked earlier, it takes 8 to 12 weeks for the drugs to show results, so the trial should last at least 12 weeks. So if clomiprimen is chosen, cardiovascular problems and closed angle glaucoma should be ruled out. As we talked in the previous slide, clomiprimen has more side effects since it's a TCA, so we have to be very careful about the cardiovascular problems and the glaucoma, and they should be ruled out. So doses of 200 to 300 milligrams of clomiprimen are needed, but titration should last for 1 to 3 weeks, and this dose should be continued for at least 12 weeks before determining a response. So if the patient cannot tolerate the first drug, which is usually an SSRI, or did not respond to a trial of drug from the other group, and is advised clomiprimen and vice versa. The third stage, in non-responders and in cases of only a partial response, includes a small dose of antipsychotics, like we talked earlier, for patients who have a personal history of tics, but most commonly Tourette's, or if they have a family history, then adding a dose of antipsychotic, especially Risperdal, has been very effective. A combination of SRIs and clomiprimen, or the addition of lithium, trazodone, Buspar, or tryptophan, these have also been seen as effective. The fourth state consists of atypical neuroleptics, thyroid supplementation, clonidine, and MAOI, and intravenous clomiprimen or clonazepam. So in resistant cases, electroconvulsive therapy or neurosurgery should be tried. So that was all about the psychopharmacotherapy in OCD. You can refer the following books if you want to know more about the pharmacological treatment of OCD. Thank you.